Good morning, everyone. I'm Dr. David Wild, Vice President of Performance Improvement, here again with you, sitting in for Dr. Steve Stice, our Chief Medical Officer. We're coming to you live from the Dolph Simons Jr. Family Broadcast Studio. Today we have Dr. Catherine Satterwhite, Regional Health Administrator for the U.S. Department of Health and Human Services, back to share an update from her perspective on vaccine distribution throughout our region. We'll get to Dr. Satterwhite in just a moment, but first, Dr. Nathan Barr, one of our infectious disease specialists, is joining us today, sitting in for Dr. Hawkinson while he gets just a few days away. Nate, how do our numbers look here in Hays this morning?
Yeah, and don't worry, Hawkinson's coming back. Stuck with me for the long term. So the numbers, the active cases are actually down a bit today in Kansas City. They're at 58. They were at 65 yesterday, so that's a fair bit. But the total numbers are really pretty steady. So 118 total cases in Kansas City. It was at 114 yesterday. So really, we're just seeing, still a lot of patients, but less in that sort of active phase at the moment, at least for today. So we'll see how that ends up, but maybe that's a glimmer of things to come. We'll see. Stable at the moment. Of those active patients, 19 are in the ICU, and that's down a little bit too from 24. Still 10 of those patients in the ICU needing the ventilator. And 17 tests pending. We did have one death in the last day, unfortunately. And then numbers in Hays, they're at 18 patients today from 21, I believe it was yesterday. And unfortunately, they had 2 deaths yesterday. And so, still a lot of bad disease out there. Still, unfortunately, people dying from this disease. But, stable numbers, maybe some signs of numbers coming down a bit, but we'll have to see what that means.
Yeah, and that sort of meshes well with the big picture. So several days now, I think today will mark at least 4 in a row at the national level where new cases per day are decreasing, and as is the rolling average, along with those, the number of patients in the hospital and also the number of deaths per day. So all some encouraging signs, I think. We've seen one other little change, and we'll maybe talk about this more with some numbers tomorrow, but in the month of January here for the patients admitted to our hospital, although the average age is up slightly, it's to 60, which is just a few years older than the average of maybe 55 to 57 that it has been, the length of stay for those that have been discharged so far in the first 20 days of the month is down almost half of what it was before. So instead of being 7.6 days, on average in the hospital, it's 4.0 for those that have been admitted in January. And some of those, of course, haven't been discharged yet, and that number will change when we get to the end of the month. But that too, I think, is encouraging. And I believe at this point, sort of initial impressions are that that's related to a smaller number of patients in the ICU. I think we've seen that every day. Our number of admissions, new admissions per day, is actually fairly steady. So it's not that there aren't patients needing to be hospitalized or there's not continued disease spread in the community. It's just that less of them are coming from places whose ICUs are overwhelmed as things stabilize just a little bit. And that's a good sign for all of us. So I'm hopeful that that continues. I am sure we'll talk much more about those things both today and tomorrow. But before we jump into vaccine discussion, are there any reporter questions on the line this morning?
Yes, good morning. Cody Holyoke, KMBC 9 News.
Morning, Cody.
Morning. Now that Kansas is in phase 2, I'm curious how the health system, if at all, is involved in that. I know you guys have been working on mass vaccination clinics for your own staffers. I'm just curious your involvement.
Yeah, great question. So our involvement, at least as of today, remains primarily in preparation. We actually haven't received doses yet this week that we could use for that sort of thing. We really have used all of the doses we have, but we do anticipate some doses today. When I say we're in the preparation phase, Cody, we've talked a lot about our mass vaccination clinics here on campus. We've actually been working to change around the locations and how we manage those patients as they come in. So the current locations we've been using, say on the university side of campus and the health education building, are not really convenient for patient parking or patient access, and could be a bit challenging, although they're definitely designed to be accessible for anyone with a disability. It wouldn't be an easy trip in a wheelchair or for someone who needed support in getting from parking lot to the HEB. So that means we've retooled to think about how we can do the same number of doses per day every day in spaces that are more accessible for patients, especially those over 65, which will be without a doubt our target as we start phase 2. So I anticipate those things both on this campus and on our Indian Creek campus starting in earnest next week, really with our efforts as we partner with the counties, both Wyandotte and Johnson, to support what is a very, very large population in phase 2, maybe a third or more of the total population of our counties in phase 2 alone. So lots of work there, Cody. We'll have more specifics next week as we actually have doses and know how this can work. But we're aiming for 10,000 or more doses per week for those patients and general public over 65, primarily in the first several weeks, I would bet, here in our facilities. But 10,000, maybe 12,000 per week if we can get the doses.
Hi, I don't know if you can hear me. Bryant Madrick over at 41 Action News. This question is for Ms. Satterwhite, so I don't know if now's a good time to ask it or later, but it was in regards to some information from Governor Laura Kelly in regards to the phase 2 rollout. She talked about the fact that at least when it comes to the federal government and their supply of the vaccine, that there will only be about 45,000 doses available. I was just trying to find out if Ms. Satterwhite, if she could speak to that number, why it's that low, and if there's any chances that it could possibly be increased. I know that there's demand all over the place, but any explanation for that number? I don't know if you could speak to that, but if you can you?
I can make a couple comments that hopefully will be helpful. First, you're absolutely right. The number one thing that we hear from states, cities, everyone is that we really like more vaccine, that we actually have systems in place to rapidly administer vaccine. We just don't have enough supply. And I think Dr. Wild alluded to that supply issue being a challenge in planning even. The other thing I want to make clear is that the federal government continues to distribute and allocate vaccines on a pro rata basis. So it's based on the population of the state. That's the way that we have determined we're going to keep moving forward at this point. So those numbers are what they are. They are proportionally the same across all jurisdictions in the United States. So hopefully that's helpful.
That's interesting. Based on the population.
Yeah. Great. Any other reporter questions on the line this morning?
Not political.
Sure. Cody again. Talking about the AFC Championship game, I know, we're in the middle of a pandemic, and this is a heck of a time to be celebrating and gathering. Just your thoughts moving into this as numbers are starting to tick down hospitalizations-wise. We have people, potentially hundreds or thousands of people traveling into town from another part of the country. Just your thoughts on that.
Yeah, Nate, I'll let you start, and then I'll come in here at the end.
Yeah, I mean, it makes me nervous, so these numbers being stable, slightly down, may be a good sign. That is not a reason to throw off your mask and, hug a stranger. This is a little nerve-wracking for me. So, I hope people will still, celebrate in a safe way. Hopefully there's a win to celebrate, and hopefully that means, people screaming on their couches or yelling across the street to their neighbors or things like that. But if, it's going to be something in public, then in the safest way possible, outdoors, small numbers, those sorts of things. It is not a good reason to be in a crowded area with hundreds of people indoors. That's a recipe for badness, for people getting sick, for continued cases and people dying. So I hope people will celebrate responsibly.
I agree. I think we're all very happy that tomorrow is another Red Friday. Excited to host another AFC Championship game. Excited for the community and of course our friends and partners in the Chiefs organization. Hundreds of thousands of people moving or traveling in the middle of a pandemic would be not good for a number of reasons. It doesn't really matter the impetus for that movement. I think the specific question, though, of, as numbers are down, can people feel like they're able to do these things just because numbers are down? I would say the very, very clear answer to that is no, even those who've been vaccinated. We continue to talk about the fact that it is unclear, primarily because we don't have much evidence right now, but it is unclear if those who are vaccinated can be asymptomatic and transmit, and if that's possible, how frequently it happens. And so masking, physical distancing, all of the pillars of infection prevention and control that we've shared for months now remain as important, if not more important now, as we begin to also be concerned about the impact of new variants, or the variants of concern that you've probably heard a bit about, that could be or look to be more transmissible. So all of those factors very much could be a recipe for its own sort of super spreader event in our community. And I think we all do need to be aware of that. The numbers, while it is comforting for all of us who could use a little bit of a breather around the healthcare delivery space, the numbers of cases and hospitalizations might be declining. That's definitely not because there's not disease in our community. And so a very, very strong encouragement to anyone out there who was considering the opportunity to celebrate with a group, whether it be indoors or outdoors. Just a reminder, we're not quite out of the woods yet.
Yeah, and if I could just mention on the lines of the variant, I just read a report this morning, now detected in 20 U.S. states, not Kansas or Missouri, but, circling us, Colorado and the upper Midwest. And I mean, it's if it's not here and just not detected yet, it will be shortly. So, this is another factor to keep in mind. And yeah, we need to keep doing everything we can to stay safe.
I'd bet money it's here.
Yeah.
Statistically, it has to be. The number of isolates that we're sequencing per day or per week is not really large enough to give us a good statistical way to say it's not here. We just haven't found it yet.
Yep.
But with Oklahoma, Texas, Colorado, Iowa, I think all having cases now, it's without a doubt here. We'll see those impacts soon enough. I think the recommendation, or the belief, the projection is that it will be the primary strand here within 6 weeks or so. We'll share some information about the impact of that. Even though it's not more deadly for an individual, the risk to a population and the risk for hospitalization and overall increase in a number of deaths as more people would be infected as we roll out vaccine, still being part of that conversation. Those things are all very concerning. So, any other media questions on the line? All right. Well, Catherine, let's jump in more with you. Thanks for joining us again this morning. I know everyone is very interested in your perspective on how our federal government and your teams, and really the region, as the federal government works a lot with state and county governments, really is doing everything they can to improve vaccination rates, which I think is primarily focused on distribution now, but there are other variables, I'm sure, in that conversation. So first, let's start with your region. How big is that? Exactly what does it encompass, and what's your role in overseeing vaccine distribution throughout that region?
Sure, absolutely. So I'm the regional health administrator, and I work for the Office of the Assistant Secretary for Health, which is part of the U.S. Health and Human Services. And Region 7 consists of the Midwest. So in a sense, Kansas City is where Region 7 headquarters are located, and that's because it's kind of right in the middle. So I work with the states of Nebraska, Iowa, Kansas, and Missouri, as well as the tribal entities that are in Region 7, at least partially or fully. And what I do is I try to provide information and support largely to state health departments, but I do also work with local health departments. And we're talking specifically really about working with COVID-19 in my normal job, which I kind of remember. We do a lot of different health topics. We talk about physical activity. We talk about maternal health. Back in the day, we even talked about youth sports, which was really fun, and I hope we can do that again. So those are the 4 states that I work with, and just really trying to support their efforts. All 4 of the states that I'm engaged with are just they keep going. They have worked on developing testing plans back in the very beginning. And then they worked on how to get new therapeutics out, which you guys had great uptake in at HaysMed, as well as across the Kansas City area. And that's one thing that our states have done a good job in trying to integrate new therapies, which help take better care of patients, which I also think is playing a little bit into the hospital length of stay as we've had new therapeutic options and learned how to better treat this disease. So that's just a high level, so you know where I'm coming from.
Thanks. And with that perspective, what's your take on how vaccine distribution is going across your region?
I think it's going well. There's always room for improvement, and that improvement can happen in a lot of things. Like I mentioned earlier, supply is a challenge, and it's really challenging to plan for a clinic that you'd like to run every day, but the supply isn't necessarily at the level that we'd like to see it because the national availability is what it is. You know, I think from a federal perspective, we continue to focus on supply and getting as much out to states for use as we can. So I do think states are using it very well. There are, some challenges with data as well. Dr. Wild, you're a big data person. I am too. We really want to be able to look at that CDC figure. If you guys haven't seen it, it's on CDC COVID data tracker, and I can send it and we can put it in the chat later. But you can see how many vaccine doses have been distributed and how many have been administered by state. And it's not as high as the truth. And what we're doing is we're working to actually make it better so that it is more reflective of the truth. There aren't tons of vaccines sitting on shelves. It's a combination of reasons, including some data glitches, including some of the way the timing, the data systems work out, and including getting providers ramped up to be routinely reporting data. We do have some providers, some healthcare workers who are administering vaccines who don't maybe typically work in that space, so they're trying to learn new systems too. So states are doing well. I think there's always room for improvement, and everybody would really like more vaccine.
Well, that part is no doubt true. The public is clamoring for it. The number of calls I think that you probably get is equal to or greater than the number of calls that we get asking when it will be my turn for all in each of the cases for good reason. You point out the delay in data entry and reporting being sort of a secondary problem. It doesn't really reflect the number of doses that are actually administered to date, or also it sort of highlights maybe in a negative way or appears to highlight the fact that there's a delay between shipping and administration when really there's some shipping time that is necessary. Then there's some administration time. We can't give every dose that we get today. We can't give it today. It may take us 2 or 3 days, even with large-scale clinics. And then there's a potential lag in the reporting. And so when people hear that there's X number of doses shipped and Y number administered, that gap that you're describing, it isn't due to the fact that these doses are sitting on shelves. I think that's what I'm hearing you say, correct?
That's correct. And to be clear, it's a mixed bag. There probably are some doses sitting on shelves that need to be administered. And I think that's true of any sort of large data source that we see. It represents a big thing, and we know that there's variation within that data source. So yes, that was a really good summary of sort of that there's time that's built into each of these steps. That doesn't mean a failure of the system. It's just time. But having said that, there are opportunities for improvement at each of those steps.
So sort of with that perspective, what do you think's going well, and what do you think are, in our region, the opportunities for improvement in distribution and administration?
States are doing a good job of ordering and allocating the vaccine immediately when it's available. So states are notified that they get X number of doses, and they waste no time. They order them and they get that shipping process that you mentioned started. So I think that's going really well. I think states are also doing a very good job of adapting to a huge pandemic, and sort of it's still new, and things change. We have these 2 approved vaccines that are approved for emergency use, which is amazing, but things change, and we're constantly reevaluating the priority populations. ACIP had meetings at different points to try to help guide states, to give them a framework to then further refine their phases. And each of the 4 states that I work with largely aligns with the Advisory Committee on Immunization Practices, that's ACIP. And but they've had to make operational decisions within those categories, and I think states are, they're forging ahead with that. They've all involved experts to really look at what the Advisory Committee on Immunization Practices, that's through CDC, what they're recommending, and how that applies to the population of their state. So they're really customizing those to the extent they need to operationalize. So ways that things can be better. Again, there's always opportunities for improvement. I think brainstorming, or probably we collectively can improve on communication. I know the public has a lot of questions, and states and the federal government are working to improve that communication. So it's not something that's not happening. I think there's always more that we can do, including really, trying to think about how we reach all populations with the messages that we need to. And some of that is reinforcing that the vaccine is safe and it works. Another one is, when are you eligible? Another one is, where do you get it? And then kind of going back to some comments you guys made earlier, I think it's always important to continue to emphasize the need for the pillars of infection that you guys talk about so much, even in a very exciting time where vaccine is becoming available.
You hit on the fact that states have been tasked with creating their own sort of more local operational plans based on recommendations from the advisory committee and from the CDC. We get a lot of questions about why states have different plans or different phasing. Both challenges with Kansas and Missouri, right in the state line, being in the middle of our metropolitan area, and also questions from patients who say, my sister or my aunt or my parent lives in Texas, and it's very different there. You want to comment a little bit on how we can, number one, why that's necessary? You hinted at it. And number two, how we can sort of help alleviate questions and concerns from the community about why those may be different plans.
I can try. It's a hard one. So just let me review sort of how this happened. So we knew many, many months ago that vaccines were being tested, and we knew that they were going to be in a limited supply when they were demonstrated to be safe and to work. So we sort of had that framework to work in. So the Advisory Committee on Immunization Practices, as well as some other national organizations, started to begin a process where they thought about the ethical distribution of vaccines. What do we take into account when we prioritize populations? We have to take things about lives saved. We have to take things about economic impact and our workforce from a variety of perspectives when we talk about critical infrastructure workers. So there were some groups who really started to dive into creating guidance for public health to use in getting that vaccine out. So those guidelines are a little bit broad. And so what states have to do is take those guidelines and, again, to use this term, operationalize. Like, what does that mean when we now get that vaccine out to our population? So most states, all 4 of my states, have a state-based advisory committee. It includes medical experts. It includes members of the community. It includes people from different business sectors. It includes ethicists, so people who are really thinking about kind of the hard ethics questions. And they talk, and they try to figure out, how do you do it's a no-win situation, and I don't use that term lightly. We want to get vaccine out to as many people as we can, as fast as we can. But we're living in a world of low supply and high demand, so we have to work through that process. And states have adopted slightly different operational plans within those sort of bans, those recommendations that were created by those larger groups. and it reflects any number of different strategies and principles that have been applied by those groups, again, to reflect the state, the population, the administration, their industries that are important to the economics of their state. So all of those things are just different things that people have to think about, and they aren't the same across states. So that's why you see variation.
Thanks. You're right. Very, very hard question. I like to think about it just maybe in the simple terms of just trying to find the right balance of broad national recommendations combined with what is important more locally in your community. And I think we'll probably see a little bit of that start to get even more specific as counties start to work through how are we going to make an operational plan for phase 2, for example. And that doesn't mean there's anything wrong with that. I think that's the question we get. Is one county right and the other county wrong, or one state right and another state wrong?
No, yeah, it's a fair question, and it's something that I understand that people want to know, and it's been interesting to see sort of the tiny decisions, because each person is actually a little bit different. And we know that maybe this person has X, Y, and Z that may qualify them in a certain phase, but they sometimes want clarity. And the groups that we define are sometimes still feel too big and a little bit hard to know if you fit into that group.
So let me ask a very sort of specific question that a lot of viewers and a lot of patients are asking us. What if I live in Missouri but receive my health care in Kansas at your facility? Is it a problem if I get my vaccine in Kansas if I live in Missouri?
No, it is not a problem. You can receive the vaccine anywhere. The federal government actually purchased the vaccine, so it can be administered anywhere.
And as far as tracking goes, we will, or we do work to sync up. Information is shared from state to state about who actually received a vaccine and who has not yet received it. And so there shouldn't be any reason from that perspective either, correct?
Correct. There is a huge data infrastructure, and all states' data talk to all the other states' data to make sure that you have a record in the system that says, I got Moderna on this date. And here's where I got it. So now that system is shared everywhere. So when you go to get your second dose, it can be added to your same record.
And maybe last thing that I'll ask before we get into some questions. I'm sure you talk to your counterparts, leaders of other regions, and hear things from them. How are they doing? And have you been able to share any information amongst your peers that has helped either our region or maybe some learnings that we have had that have helped other regions?
Yes, I do. I talk to a lot of people at all times of the day, it feels like. Here, the big thing is, while our population is different across the United States in many ways, and states are different across the United States, we are all in this together, and we're actually all going through very, very similar things. So we're more the same than we are different in the successes and the challenges that we're facing across the country. Within Region 7, yes, we have done some things that we'd be able to share with others that are hopefully helpful and have allowed people to maybe, so one thing we've done, we've tried to figure out innovative ways to deliver monoclonal antibodies in different settings. It was a newer therapy that was for outpatients, and we're very good at giving medicines in the hospital. But this new medicine was a little bit harder, and you guys have probably talked about it on the show, because it was an outpatient medicine. So we've worked to try to develop some best practices that we've been able to share. And that's happening across the board. We are sharing things. We are trying to make things better for everyone.
Yeah. And we have talked about monoclonal antibody therapies and even our infusion center and our ability to offer them that infusion to patients.
And we're talking about it on Monday.
There you go. And much more conversation on Monday.
We're going to have a patient who's gone through it. So.
All right. Well, let's open it up to some questions from the community. I know, Jill, they've been coming fast and furious.
They have, and we love that. And they have the best questions ever. I'm going to go to Carol because she has she keeps putting her question on, probably because she thinks I'm passing her over, and I'm not. And I think it also is a good question because a lot of people are asking about who is in phase 2. And she has an 87-year-old mother with hypertension, 3 years out from cancer, still cannot get the vaccine, she says. I'm guessing mom is not in a nursing home and mom is probably still at home. And so there's a couple of things here. Why can't mom, will she be in phase 2 and how can she get a shot? The other thing is that Carol says, I have just signed up on every alert list possible. Are there any challenges if you're signing up, or is that okay on multiple lists?
Yeah, lots of questions there, Carol. Thanks for being persistent. I promise Jill isn't ignoring you. She does the same thing to me.
Yeah.
So the short answer is an 87-year-old with or without comorbid conditions would be considered in phase 2, at least by the Kansas guidelines, and for sure, I think, in the Missouri plan as well. It's one thing to say, starting today, we're entering into phase 2. It's something very different to say that means that a lot of the people in phase 2 will actually be able to be vaccinated in the next day or even week, probably. So I think I mentioned it's about a third or more of the Johnson and Wyandotte County populations that fall into phase 2 in one way or another. And that may be as many people in Johnson County, for example, as 150,000. That's a lot of people to vaccinate. That's going to take some time. It's going to take weeks, in fact. And so because we've said we're now starting phase 2, I think even those in that population, right, an 87-year-old mother of yours, for example, may very well find that it is weeks before a vaccination appointment can get scheduled due to supply and the ability to vaccinate. I mean, that's a lot of people, even in one county, to vaccinate. And multiply that by more than 100 counties across the state of Kansas, right? A lot of counties in a 4-state region. I can't even begin to understand the number of counties and individual interactions that Dr. Satterwhite and her team have to help with in that perspective, even in just in 4 states. So those things are going to take some time. As far as alert lists, registering, we've created a way for the community to signal to us that they'd like information or like to be contacted when it's their turn to receive vaccine here. And we'll be turning that on now that we're in phase 2 very, very quickly. It is sort of an alert list, I think, that you're describing, or something similar. It allows you to queue here. And signing up for those would not be a bad thing. If you are on multiple lists and you find that there's a place that you can get an appointment very quickly, take it. We're all of the mindset that the faster we can get vaccine doses to patients, the better off we are. And there's no pride or hurt from going somewhere else or going to the first available space. All that being said, I think you're doing the right things. You're worried about when can you get your mom a vaccine. You're paying attention. You're asking the right questions, and you're signing up for every alert possible. And so I would tell you, keep doing what you're doing, and it won't be too much longer for the first dose. But I'd be remiss if I didn't follow that up with, but that doesn't change much. For an 87-year-old with risk factors, that won't mean that you'll be out and about in the community without a mask, without physical distancing. It simply is another tool in our tool belt to prevent disease at the individual level and help get our population back to normal. But that 80 or 85% of the community that will need to be vaccinated to really change how we're behaving is still many months off.
Yeah, I guess I would just add, I agree. I think it's really a smart thing and a good thing to sign up for as many of lists, alerts, et cetera, that you can, so that you can get a dose as soon as you can. But once you are fortunate enough to get that first dose, please make sure you still pay attention to those other lists, so that if they offer you appointments, you can say, oh no, I already have it, so that another person can get that vaccine. Because the last thing we want to do is have systems sort of waiting for people to get back to them or holding up doses. We want everybody to be able to get these as soon as possible. But yeah, take the first chance you can get and sign up everywhere that is reasonably done. Yeah.
Dr. Satterwhite, anything to add?
Just only briefly, there will be as we roll into future phases, there will be more options, more locations where you can get a vaccine. So KU is one of those, but there will also be more pharmacies that will be rolling on. The federal government is working with all the states to identify some pharmacies that can begin to serve that population in phase 2. So those aren't ready yet, but it is something that we hope will be ready very soon. So more options will be coming. We understand certainly everything you're saying and empathize with your situation.
Suzanne wants to know, since the states are receiving vaccine based on population, are the counties being distributed in the same manner? Why is Johnson County's allocation so low?
Well, Dr. Satterwhite, I'll let you maybe start and I'll add color commentary if I can.
The state allocations are being based on population. All of the decisions beyond that, so to local health departments, to hospitals, are being made by the state. And each state has different criteria that they put into making those decisions.
And so for the specific question about Johnson County, I can't say that I or really anyone from our team are involved in understanding exactly how many Johnson County is receiving or asking for and how that determination is made at the state level. We've had many of the same questions. What we know is that we've heard stories about individual decisions on a week-by-week basis. And that may be clouding the bigger picture. So over the course of several weeks, it does seem like Johnson County has at least been able to catch up, maybe not get ahead of the curve, if you will, but it is a bit, at times, a bit of a mystery. And that determination, as Dr. Satterwhite said, is really made at the state level. And so we continue to advocate for our communities and for our patient populations and for our neighbors, and trust that those who have a very, very difficult job at the state level in determining how this happens each week are doing it to the best of their ability.
And Johnson County has agreed to come on February 3rd and talk about what's happening there. And we're also trying to get Shawnee County, but they're not confirmed yet. So we will see. Joyce has a question for Dr. Satterwhite. A week ago on this program, Dr. Alan Greiner with the Unified Government said Kansas had pushed out more vaccines to rural counties. Do you know, is that still occurring?
Kansas has done an excellent job of ensuring that rural counties have equitable access. In fact, we've seen that across Region 7 and in many parts of the country. So I don't know if that is still the same in terms of statistics, but it is something that has been done very well.
Claudia asks, is the prorated based on the number of seniors or all ages? Is it people in general?
So I'm assuming that's the question about how federal doses are allocated based on population.
I believe it is just state population. There were a number of different strategies that were considered, but state population, I believe, is what we do it on, the whole population.
I'm fairly sure that is correct, Catherine. I think Dr. Norman, I believe, shared at one point that Kansas has roughly 2% of the U.S. population in the last census or the last update, and so any week where doses are available at the federal level, Kansas gets about 2% of the doses available. And so I would lean towards agreeing that it's overall population of the state as of the last official federal population number.
Jeannie writes that her niece told her that 100 people died from the vaccination in California. I have not seen this in the news. Is this true?
So I'm not aware of any reports such as that. You know, there has been some concern in some circles, I guess is the way to say it, regarding deaths for people that have had a vaccine dose. But I think I would make it really clear, the places where deaths have been documented in people after the vaccine doses, they've been investigated very thoroughly and they're not from the vaccine. So what is being seen is essentially people that are dying of other causes after they've had a dose of vaccination. So, for instance, there was this report from Norway of 33 deaths in very elderly people, many with terminal illnesses that had gotten a first dose of a vaccine. And some of them passed away. And so, these deaths were investigated thoroughly. They were not related to the vaccine. They were from the underlying conditions that these people had that made them so susceptible and concerning for COVID, but it was not related to the vaccine. It was, things like cardiac disease or brain hemorrhages, things like this, bad medical conditions that can make people sick and kill them, but it was not the vaccine. The vaccine has not been linked to deaths.
Yesterday, you gave a stat about allergies relating it to penicillin.
Yeah.
Share that.
Yeah, yesterday, yeah. So, there was a big MMWR report from the CDC. It was 1.9 million doses of Pfizer vaccine that were given in that report. And they reported 21 cases of anaphylaxis. And so, there was an anaphylaxis in the studies. That was a smaller population. And this is what you sort of would expect, is that when you give millions, maybe you will have some anaphylactic reactions, bad allergic reactions, that we can intervene on, by the way. And so related to penicillin, this is much lower than penicillin. Penicillin is a really common antibiotic. We use it and its relatives all the time. And there's about 100 to 500 cases per million of anaphylaxis from penicillin. So, so we're talking, 10 times what we see with this vaccine at least. And so, just to try to reassure everybody, anaphylaxis is very uncommon with this vaccine. But, that's why we watch people after it. In fact, in that MMWR report, 71% of those anaphylaxis cases were within 15 minutes. So that's why we're watching people after the vaccination, so that if that does happen, even as rare as it is, we can intervene and we can help people get through that.
And a follow-up to the,
I just cannot reinforce enough that we will see patients who die after they receive a vaccine. Any population, right? Any population we look at, especially when it's large, like the number of patients that have been vaccinated in California, for example. In any population, there is an inherent daily or weekly or monthly death rate. And that will happen. Don't be surprised. You should expect to see reports that someone died a week or 2 weeks after they received a vaccine. That's true of any treatment. What we're saying very, very clearly here is we have no evidence at any point of deaths caused by a vaccine. When we investigate those deaths, they're due to other things that were going to happen anyway. They would have happened regardless of whether that patient had that vaccine or not. And so that point is really, really, really important. Don't get scared if you see something that says there was a patient who died 2 weeks after they got their vaccine. Because unless we have a string of cases where we can show very clearly that outcome is caused by the vaccine, and again, we have no evidence to this point of that, then we're talking about the natural things that happen in any population.
Yeah. And one thing I think I don't believe I said, which is probably worth saying, is in that Norway report that was out there, these were 33 deaths again, people that had received a first vaccination. In fact, 45 people a day die in Norway in long-term care facilities. That was the same population described in that report. So I think that's really important context. And it's of course sad. We don't want, we're doctors. We don't want people to die. This is our calling, to try to help people and make people healthier. But this isn't from the vaccine. That's the take home, is that the vaccine is not causing deaths, and it's safe. And please, when somebody calls you and says it's your turn, take it.
we have one viewer that asked, does it help if I take Benadryl if I'm worried about that?
Yeah, so there are, will it help? I don't know. I mean, it's hard to know if you're going to be one of those people that has an allergic reaction with how rare it is. So I think, for people that have some type of mild reaction to the first vaccine, say you get hives or something after your first vaccination, in that case, probably pretty reasonable to think about taking Benadryl before your second vaccination. I'm not sure it's needed beforehand. Me personally, I wouldn't do it because it would make me go to sleep, and I probably wouldn't make my appointment because I'd fall asleep. But it's not an unreasonable thing to do. It's not gonna, hurt the vaccine uptake, for instance. It's still gonna have a good response to you in terms of your immunity, but it's probably not necessary.
All right. Gary wants to know, Dr. Satterwhite, he said, I'm 76, I live in Platte County, and they tell me there's no vaccine in Platte County. Is that true?
So There has been vaccine in Platte County. There may not be at the moment, and it's possible that there may not be vaccine for the population he's in. So I don't know. Every county has gotten vaccine at one point, but supply is low.
All right. Pat has a son with medical problems, and his doctor says he needs a COVID vaccination as soon as possible. But he would be in phase 4. He is 52 years old. How does he get him moved up in a phase?
Well, this question comes a lot. How do I get my loved one moved up, or how do I get moved up in a phase? And I think the reality, the answer to that question is you probably don't. Moving phases at the individual level based on an individual set of circumstances is probably not going to be a frequent occurrence. Of course, the recommendation of your individual physician to get a dose as soon as possible is very fair, is very much, I think, the answer we would all give our patients. As soon as you're able to, you've heard us say that today, as soon as you're able, please get your appointment and get your vaccine. The sort of crux of this conversation is the evidence that we have to date about who is at an extremely elevated risk of death from a COVID infection would say that primarily age and maybe having a transplant and maybe to some degree obesity.
Yeah, there's certain other comorbidities that are there, but I mean, that's part of the question, which is a little difficult, right, is we don't know which underlying conditions we're talking about in this individual. And so, the risk can vary a lot by what conditions we're talking about. So if the person we're talking about clearly has conditions that fit in a phase, then they'll fit in it. But I think if it's for some reason they have maybe some underlying condition that doesn't quite qualify them for that phase, I think that's probably, it's probably not going to be possible to move phases. It's all relative risk, and this is, I think, as Dr. Satterwhite talked about, there are so many parts of this, and there's a lot of valid concerns from a lot of different ways, and states and counties are trying to deal with this the best way they can, and they're making good decisions in good faith. So I think we all have to keep vigilant, stay safe, and give a little grace until we have that opportunity to get our vaccine, because so many people want it, and I think we all recognize that, but it is a massive problem, and unfortunately we just don't have enough to give everybody that we would like right now.
And again, I'm going to sound a bit like a broken record, but vaccination is just an additional tool, right? You know how to keep your loved ones safe. We've been sharing with you the things that we know work to prevent infection and transmission. Those things will remain important, again, until you've had your vaccine and after. So at the individual level, while of course we all want every tool available to us, we know, just like we know in our own employees, we know how to prevent transmission in the healthcare space. We know that the things that we've been sharing with you around the principles of infection prevention and control can keep you and your family safe until it is your turn to add the tool called a vaccine dose to your tool belt.
All right, a couple more questions. I know we're going long, but lots and lots of questions. Sean would like Dr. Satterwhite to clarify. He goes, did I hear her right? Are states actually prioritizing people based on the industry economic impact that they work in?
The consideration of critical infrastructure workers is being taken into account at different states. There's a national definition of who a critical infrastructure is, much like how we have broad groups of populations eligible for vaccines at different phases. Critical infrastructure workers are broad groups. So that determination, which the Advisory Committee on Immunization Practices did include in their recommendations for determining vaccine priority, are being considered and refined at a state level based on any number of factors.
Susan wants to know if doctors could clarify. I'm not sure I understand why non-Kansas residents can come to Kansas to get vaccinated, especially since the number of doses the state receives is based on state population. Unless there are frontline healthcare workers in Kansas, that means non-Kansas residents are receiving vaccinations allotted for Kansas residents. Can you explain?
So I'll try. Just like non-Kansas residents someone who lives in Missouri and receives their health care here may get a dose in Kansas. The same is true in reverse. We have a number of our patients here who have conditions that require them to seek treatment for very, very, very specialized services at some larger institutions in other states. And they've already received their doses in that state. Texas, for example, we know that has happened. Kansas patients have traveled to Texas to receive their dose simply because they have a connection to a healthcare delivery system in Texas that had doses to give to that population. So it's not like it's a one-way street. It's bidirectional. Yes, doses in general are allocated in number by population to each state, but that doesn't mean that Kansas is only going to get as many doses as we have population. As long as we are ordering and have need and doses are available, we will continue to get them. So it's not like someone is taking a dose from a Kansas resident. It's taking a dose that is purchased, as Dr. Satterwhite mentioned, by our federal government to supply to everyone in our country who needs it. And those things in general, and I think in principle, will work themselves out. I don't know. Anything to add, Catherine?
No, you summarized well.
Yeah,
All right.
I mean, I think I would just add, I think, it's an important principle. We're all in this together. And so, those lines exist. There's state boundaries and things like that. But, how many times do we cross over that state line in this metro, right? All the time. And so, I think we have to look at it a little more broadly and realize we're all in this together as an entire population. And I get the concern, but I think we really have to sort of, we're hoping everybody can get this vaccine, not strictly on one side of the state line or another. And however that happens, as soon as it can happen, that's great.
And last question for today. Tom wants to know, are Pfizer and Moderna providing vaccine according to the publicized production of 20 million doses a month, as promised?
Dr. Satterwhite, do you have any insight?
I don't have any insight on that. I'm sorry.
Yeah, neither do we. I don't really know even where to point you to get that question answered specifically, unfortunately.
Right.
All right. Well, tomorrow, Amanda Cackler, our Director of Infection Prevention and Control, is back to help answer your questions from this week that we didn't get to. We look forward to that. I'll also tee up some conversation for tomorrow. We're regularly getting questions about our employees and how many vaccines we've given and what our percentage of uptake is. And so I thought I'd give you just a little teaser, an update. So we have administered more than 10,000 doses of vaccine here on our campus so far to date. And through the 19th of January, we had given a total of 9,796 unique patients first doses. Just over 500 of those doses were to students in our School of Health Professions, School of Nursing, or School of Medicine, those students who are actively working in patient care environments to complete their education to make sure that we have healthcare workers next week, next month, next year in the pipeline. We've also been partnering with Johnson County. We've administered 330 or so first doses to Johnson County healthcare workers to help close some of their gap as we've had available doses. That leaves about 9,000 of our employees here who've received their vaccination on our campus, and then we were able to partner with the federal healthcare center, the FQHC Vibrant Health in Wyandotte County, for another 517 of our employees to receive vaccination there. So that equals just shy of 9,500 of our healthcare workers and employees who have received their vaccination, either here in our campus, on our campus, or at Vibrant. And that's out of about 13,200 total, which means 72% or so of our employees, our healthcare workers, have actually received their first dose of vaccine. And there are others that are scheduled who needed to delay by a week or two for some reason. Either they've had COVID recently and wanted to wait, they needed to for other reasons surrounding procedures or surgeries that they had planned, or you can imagine lots of reasons. So we expect that uptake to continue to climb. Last week, I think, or 2 weeks ago, it was around 62 or 63%. So we've seen that benefit. And we'll continue to be transparent with that as we get it. I'm sure that there have been more doses yesterday as well that aren't reported in that number. And to start to explain the thought that that probably is having an impact on our number of healthcare workers who are ill. We regularly get questions about our number of current positive employees. That number yesterday was just under 90. I think it was 87. Which is down significantly from our peak in November. We also only had 68 employees out either awaiting testing or awaiting test results yesterday, which is a significant decrease from our peak. So I'm hopeful, if you see the trend, and I'll share this tomorrow graphically, if you see the trend, it does appear that vaccination in our healthcare workers is preventing them from being ill, being out, needing tested. So all good signs as it pertains to questions about staffing concerns and our ability to meet the needs of our community as it pertains to healthcare. So much more on that tomorrow. As we wrap up this morning, Dr. Satterwhite, any final thoughts?
No, I really like we're all in this together. Let's keep on remembering that for all the things, for keeping your family, keeping your neighbors safe, and getting that vaccine when it's your turn and when it's available. Thanks.
Dr. Barr.
Wear your masks, keep your distance, do it for yourself, do it for your loved ones, do it for people you've never met but who you might save by doing it.
And I'll wrap up with a reminder that our healthcare workers, right, are receiving their vaccine. We just talked about that. It is important when it is your time, your turn. When you get the call, please do schedule your appointment, get your vaccine. We know it's safe. We know the benefit both to you individually and to our population and community. And to echo Dr. Barr, in the meantime, we know the things that keep you and the ones you care about safe. Continue to mask, physically distance, wash your hands, avoid large gatherings, keep your bubble small, all the things that we've talked about at length as we continue to work really tirelessly at making sure that vaccine is available as best we can to everyone in our community. So we will end today with a little bit of a video pack about why our employees receive their vaccine. We've had questions this week around the 4 Coffee County, Kansas nurses who had refused to administer vaccine, voicing potential concerns over side effects and safety and whether the vaccine development had been rushed and whether the evidence was there to support vaccination. I think the totality of our evidence shows us that the vaccine is safe. Both candidates, right? Both currently available candidates. That allergic reactions are very rare and, as Dr. Barr mentioned, treatable. And again, rarer than we see with penicillin. So our evidence has shown that COVID-19 is deadly and the vaccine is safe. As we wrap up today, we leave you with the words of several of our frontline workers who have made the choice to receive the vaccine and their reason why.
I vaccinate for all the patients that we've lost here and throughout the country who never had the chance.
I vaccinate to protect the community that I serve.
I vaccinate because I want to protect myself, family, co-workers, and my community.
I vaccinate because I want to help save the world.
Because I have a 4-month-old baby to protect at home.
So I can protect my children, the rest of my family, my friends, and patients.
I vaccinate for my immunocompromised husband, my newborn baby, and so I can smile at my patients again.
I vaccinate because I'm a single mom. And my daughter needs me.
Because I want to hug people again, and I think it's one of the most altruistic things you can do.
Because getting the COVID-19 vaccine is one of the most fulfilling public health acts I have participated in my 43 years in healthcare.
Because this is the power that I have to help end this deadly pandemic.